Hi everyone, my name is Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital and I run the Neocardio Lab. And today the goal of this presentation is to give a really brief recap of some of the basics about lung ultrasound. Um, so I'll share my screen. I have nothing to disclose. So usually lung ultrasound is typically obtained using a linear transducer. It's typically probes that have higher frequencies and they have a linear footprint and they're able to capture superficial imaging using ultrasound. Now we know that air is typically the enemy of ultrasound because ultrasound images are being produced by the reflection of ultrasound waves towards the probe once they bounce on dense structures. So obviously, if it's going through air, it's not rebounding, and so it appears very black. And because lungs are typically filled with air, the ultrasound images are typically going to be mostly a reflection of artifacts that are being produced based on the underlying structure. So here you can see two types of linear transducer. Here you can see what we use often in the NICU, which is what we call the hockey stick transducer. And it's also a very good transducer to use when you're doing vascular access. So the typical neonatal scanning regions that have been described are the score by Badinal. And if you go on the Neocardio Lab section on point of care ultrasound and you go into the lung ultrasound section, you will find um, a video discussing, performance of lung ultrasound on a live subject. So I will show you what I mean by that. On the point of care ultrasound area in lung ultrasound, you will find a video of the performance of a lung ultrasound in a neonatal period. And I'd like to thank the family who've accepted that we filmed this for matter of education purposes. You'll also find some great videos that were produced by colleagues Dr. Lauren Ruas on the clinical application of lung ultrasound, as well as other resources, one being the BRAT scoring system. So this typical scoring system. And so I will reshare my slides to provide some context. So typically we separate the lungs into 6 zones: the upper zone, the lower zone, and the lateral zone for the right and left-sided lung zones. And it's important to be aware that there's different classification depending on the age. And so in the pediatric and adult world, they'll also include some of the posterior zones of the back, which may be very difficult to obtain in premature or critically ill newborns in the NICU. So it's typically not something that we routinely do for the scoring of lung ultrasound in the newborn. And there's some publication discussing the use of a curvilinear ultrasound in the subcostal region or subxiphoids regions, so really under the costal margin, to try to capture some of the lower lobes information of the lungs using curvilinear ultrasound. But today I won't be showing this. I'm really showcasing the most classical use, which is the sixth lung region. So the way we do it is, as you can see, this is our probe, and the marker of the probe is typically oriented towards the neck. The marker for the hockey stick is typically the tip of the hockey stick, or on a linear probe, it's typically you'll see an indentation or another element that's been added by the manufacturer to indicate the position of the image relative to the screen. And so we typically will bring our probe towards the upper chest in a linear format vertically, so really kind of perpendicular to the costal margin. And so we'll have the right upper lobe, and then you typically have the nipple line, and just below the nipple line would be the lower lobe or the right lower lobe, and then just along the axilla, so really on the side and at the mid-axillary line, we try to be perpendicular to the skin, and we get the right lateral lobe, or the equivalent on the left side, the left lateral lobe. And so typically you would like to have in tiny premature infants, you just put your probe and you kind of see the entire segment. But in bigger babies, term infants, you might need to slide your probe in order to get a full sense of the entire lobe. Same thing in the lower regions, you want to slide until you see the lung to liver margin or kind of the lung to the spleen margin in order to assess the full scope of what's happening in this pulmonary regions. And so the typical scoring system has been derived from this, from, I guess, the Bratt and al. Article that's been one that describes a lot or very well how to perform lung ultrasound in the context of neonates. And so typically we have a score that goes from 0 to 3, 0 considered to be aerated and 3 being very densified. And the idea is that when you put your linear probe, you'll see that you get first your ribs or the cross section of your ribs, which are cutting through. And then eventually you see a pleural line, which is typically a denser element, and which will appear very bright because you get a lot of ultrasound waves that are going to bounce back to your probe. And so we'll provide this white line. And often as you get sliding of your lungs along the pleural line, you'll even see some of these little kind of flames of white that we call comet signs. And it's just really the reflection of the motion of this pleural line. And in lungs that are very well aerated, you get artifacts of the reflection of this pleural line along the lungs that are filled of air. And so typically you get kind of these horizontal lines around that we call A lines, and which really are the reflection of this pleural line that is being kind of artifactually reflected or mirrored along the entire zone of the lungs that is filled of air. Score 1 is typically when you start having these kind of white B lines here, which are really areas that are marking a bit more of a denser parenchyma. You see here that we see some of the coastal shadows, which are marked by they're really dark on the ultrasound, but I've put some white dotted lines to show you these kind of dark areas. So basically the ribs are shadowing what's under it. So it appears darker, especially in the lung that tends to be a bit more dense. Then you start having these lines or white kind of vertical lines that are densifying together. And so we call these coalescent B lines. And when you start seeing kind of these zone that looks almost like a liver or consolidations, we score it as a 3, and it's often like the hallmark of atelectasis or alveoli that are very, very dense and condensed or filled with fluid, for example, or even like as an infectious process or pneumonia, which is very difficult to tell in a newborn whether it's an atelectasis using ultrasound or if it is a pneumonia, but it's something that they use a lot in the emergency room in kids who are coming in with fever to see if there's signs of pneumonia, for example, when there is consolidation, just because of the clinical context, knowing that a kid who's been coughing for a very long time and has a consolidation is possibly a pneumonia, although you cannot tell if it's bacterial or viral. So this is the example from the actual article by Bratt and al. Of these pleural lines and the reflection of these A lines, which are these very linear white lines. And then you can start having these vertical white lines of lung that are a bit more dense. And so up to 3, it's considered normal, but when you're 3 or more, it's considered that your lung is a bit more dense. And then you can have a complete, almost like whiteout of your lung when the lung is extremely densified by, for example, pulmonary edema or some degree of respiratory distress syndrome. And because of that, you get, a denser lung pattern because the alveoli are more collapsed in a uniform fashion. And it's very typical to see in, for example, transient tachypnea of the newborn that you have upper lungs that is more aerated and lower lung that is more densified, and we call this like a transient transition point where there's this like kind of very clear zone of A lines, very aerated lung, and then suddenly in the lower lobes you get kind of this pattern. Um, and then finally you can get consolidation when you have like areas that are significantly collapsed or atelectasized. So this is an example of the reflection of the pleural line causing these A lines. And here in a healthy lungs, where you see the pleural line in motion, you see the ribs in cross section, you even see the muscle layer around these, so these intercostal muscles, the pleural line in white, and eventually these A lines in motion that are the reflection of this pleural line. Then you have situation where you start seeing these white lines or B lines that are actually lines that are supposed to extend up to the end of your capturing of your field of capture. We see here a bit of a thymus in this particular patient. And so B lines do indicate a bit of filling in the interlobular septa. And so, it's very normal to have some of them, but when you start having many in one lobe, you start considering that there might be a bit more densification of the lungs. This is an example of a patient with more what we call coalescent B lines. So really there's almost like complete densification. This is in a lower lobe of the lung on the right side. We can see some liver here that appears here. This is a liver. And then on top of it is a lung. We can see the ribs here. We can see the pleural line, and we can see that it's quite dense in terms of the texture of this lung. So that would be more of a score number 2. And then finally, you have situation where you get like almost like complete hepatization or consolidation with air bronchograms. And so it looks like this, that along your pleural line, you get like a very dense appearance. This would be a score 3. So you can use also what we call M mode or motion mode, which basically will trace a line along your image of interrogation. And typically in newborn, we like to have at least 3 to 4 centimeter of distance between the probe and the depth in which you're interrogating. So it gives you a sense of almost the entire lung in some of these patients. And so when you put an M mode, you get to see the motion along this line throughout time. So time is on the x-axis, and whatever appears through this line will appear here. And you can see that the zone on top, which consists of the skin and muscle layer, will appear here. And the zone on the bottom will be kind of the lung, with the brightest part being the pleural line here. And so we can see that there's definitely a difference between this zone, which is not really moving much during breathing, and the actual lungs, which are sliding and creating a bit of this fizzy appearance. So we call this ocean on the beach kind of sign. And the idea is that, the ocean is kind of this more proximal part to the probe. And then this area is more the lung, where there's a sign that the lung artifacts are moving appropriately compared to the zone on top, which is just skin and muscle. And so in this case, there's no pneumothorax in this particular zone of the lung. When compared to these 2 scans where we see ribs, we see muscle, we see a bright white line, and then there's this area where we almost see like kind of a reflection of these ribs, like a mirror of these ribs. And so that's already like kind of a red flag. Why is there a mirror here of the ribs? And typically when you get mirroring artifacts, it's often because you have areas that are filled with air, for example, that could be giving you this artifact. We even see it here, 1, 2, 1, 2. And we see kind of like the direct reflection of the pleural line, but with no motion. Basically, this line is not moving and this line is not moving either. So this is more of a concern of what we call the barcode sign. Barcode because you just get pretty much the air that infiltrates the cavity will just be stagnant. And so you don't get any fizziness from the motion of this lungs, and it just looks like kind of straight lines all across. And that's a sign that there is a pneumothorax under the ultrasound. Now, one of the issues is that you're able to see that there's an ultrasound, but you could pick up very tiny air leaks that are not necessarily clinically significant. And I think more and more in neonatology, we're realizing that a lot of these air leaks in many patients are not necessarily something that needs absolutely to be addressed or drained, unless obviously you have tension pneumothorax. So there are many cases of patients who have, some degree of air leaks that will be totally fine on respiratory support like CPAP, sometimes even in room air. And sometimes just after treating their RDS or giving time, this air leak will completely disappear. So, I'm not here to discuss the controversy about whether or not we need to drain small pneumothoraxes or patients with minimal clinical symptoms who do have air leaks in the neonatal period or even a bit of oxygen. My personal approach is that I tend to be very cautious before draining air leaks in a patient that doesn't seem to be quite symptomatic or that the symptomatology seems to be stabilized by interventions like respiratory support or CPAP. But these are obviously patients that you want to keep an eye on because you want to make sure they don't become into a tension pneumothorax or that they deteriorate or decompensate, and you have to be ready and in a place that has the expertise to be able to drain these air leaks if necessary. And so you won't be able to quantify how big this pneumothorax is, but you know, if you don't have access to X-ray, for example, or X-ray takes a lot of time, or you've been X-raying this patient many times and you want to avoid radiation, it's definitely something you can use as a tool to either diagnose, follow, or actually confirm before getting an X-ray. So it's something to consider. But the gold standard, of course, remains your radiography, which provides you also a sense of how big the pneumothorax is and what's happening to the underlying lungs in terms of the recruitment or the diagnosis. So here you see an example again of a normal versus an example of when you have a pneumothorax, which is just, these kind of straight lines all across because of the air that is being leaked in the cavity. So here I'm giving you an example of a live M mode where we see nicely actually the lung sliding with the pleura along the two pleural. So we have the visceral and parietal pleura with a bit of liquid in between, and you see the lung that is, moving quite nicely up and down. We see that there's a bit of B lines, but there's also A lines like the straight white lines, and under it you see the M mode as there is motion of this lung, and there's no signs of pneumothorax here. I do think that sometimes in lung ultrasound, what could be interesting is to see diaphragmatic motion. You can appreciate to some degree in 2D the diaphragm here, the liver, and there's part of the lungs here with a bit of that under the lungs pleural line reflection. So you can see these kind of white line reflecting from the pleural line. And if you put an M mode through the actual diaphragm, you can see the motion of this diaphragm. Now, this is an interesting finding whenever you're concerned that there might be like phrenic nerve issues, like post-op surgeries of, for example, like esophageal atresia or post-op in some of the thoracic surgeries. In this particular context, I wanted to show there's a difference here where you see a clear diaphragm and on the other side, there's no diaphragm. This is the patient who has CDH. So there is right-sided diaphragm, but nothing on the left side. You can use ultrasound to see the motion of the diaphragm, but obviously if you're on mechanical ventilation, you would need to put the patient on some kind of CPAP or CPAP pressure support, because if you're actively giving ventilation mechanically, the diaphragm might move passively and you might not really understand if the diaphragm is moving spontaneously. So it's definitely something that can be an add-on to some of the evaluation, with fluoroscopy being the gold standard to assess diaphragmatic motion. And obviously, if you're unsure, you'll need expertise from your radiologist to either confirm or infirm issues with diaphragmatic motion. But it's a quick point of care ultrasound test that you would be able to do at the bedside. I think, one of the main, for me, use of chest or lung ultrasound is really to rule out massive or, even sometimes subtle pleural effusions or reaccumulation of pleural effusions when you drain pleural effusions, for example, in lymphatic diseases, or if there is a leak from a PICC line, for example. So we've had cases where X-rays showed a complete dense lung and people were ready to tap, and actually it was atelectasis, and it was just a dense lung from being completely collapsed, and there was not necessarily a tracheal shift, and it was really the lung ultrasound that showed that, wait a minute, let's not tap because this is lung. And then, in patients with high drops or with concern, so we had cases, for example, of pleural antenatal pleural effusion where it's been drained or tapped prenatally, but not the whole pleural effusion was tapped. And so ultrasound was very useful in the delivery room, for example, to quickly see, how much pleural effusion. And so liquid will typically appear very dark and very, versus lungs appear more white. So here it's very dark compared to lungs on the other side, which you can see here with all these lines reflecting from the pleural line, versus on the actual right chest, it was very dark. So this is the right chest, and it's very dark, and it was filled of liquid. And sometimes you can even see, if you have more skills with ultrasound, like you can see septations in the liquid, or you can see kind of densities in the liquid. And, it can give you a sense of how this liquid is being formed. And that's after the drainage where there's no more of this darkness, neither on the right or the left side. So we tapped it, this pleural effusion, and we were able to drain nicely. So this is what I meant by the transition point, or what we call the double lung point, where you have your linear probe on top. You see here some skin tissue and the ribs and the muscles. You have the shadow of the ribs, and you can see that in the upper field, on this right lung, you have nice linear A lines with a bit of B line. So one B line here, one B line here. And versus in the lower lung field, if you're really in the middle of the chest, or as you're transitioning down or sliding down your probe towards the liver, you can see that this is very white, and it's more of a consolidated B-line pattern. So you're clearly having a difference between the two areas, and this is very compatible with a TTN. And this patient does, just would need time and some support with CPAP as there's the progressive transition. RDS is a bit more of, densification of the lung. So as we know, it's typically a situation where you are, you don't have enough surfactant, and because you don't have enough surfactant, the surface tension is very high, and so you get a lot of alveolar collapse, small lungs, air bronchograms on the X-ray. And then here what you see is that these lungs have a lot of consolidation, and it's very dense. So it's consolidated B lines all across. So for the right lung, right upper and right lower, you see here consolidation along the pleural line. You see it here as well, and here as well. And see, this is a patient who has, RDS with quite dense lung on the upper and lower portion, and so it's not TTN. And sometimes you put your probe and you find like kind of all these. So there's the heart, and then here you see all these kind of areas that looks like bubbles and circles and linear lines. And this is a patient who has a congenital diaphragmatic hernia. And so what you're seeing is actually bowels under the ribs. Now, in that particular case, we already knew the patient had CDH, but in some centers or remote places, you may only have an ultrasound available to rule out these diagnoses. And, in some situation where you don't have air entry and patient's respiratory distress, it might be worthwhile making sure that you're not going to tap what you think to be a pneumothorax and it ends up being bowels. There's an emerging literature to try to better understand if ultrasound can be used for like endotracheal tube position. Typically, this is a view from the suprasternal area where we see the arch of the aorta. And what you see here are like two straight lines, and these two straight lines is an endotracheal tube in this particular patient in the trachea. We can see it also nicely here, the two straight lines on this image on the right. That is just finishing at the area of the great vessels. And so it's been described, and here you can see it as a still frame. It's been described that, if you arrive closer to the aortic arch, you're probably starting to get a bit too far or too deep with your ET tube. So here's the aortic arch. This is the tip of these two lines, and it's just before arriving to the arch. So, it's one way to assess positioning, but I would say that personally in my practice, I use mostly x-rays for that, especially in tiny patients, because I always want to avoid being endobronchial, but, we auscultate also, but it's definitely something emerging and something possible. And some experts have gained a lot of skills in doing this using lung ultrasound, so it's definitely something to consider. And some people are doing also what we call the cross-sectional view, so looking at the view, but cutting through the actual, turning the probe really to be kind of linear around the suprasternal area and parallel to your claviculas. So it's useful to rule out pleural effusion versus complete atelectasis. It can be useful for diaphragmatic motion or rapid evaluation of a pneumothorax if you take time to get an x-ray or you don't have access to the x-ray. I'll be honest that in our unit, we don't use it for surfactant eligibility. And the reason is that we use clinical criteria, and typically we use an approach that's been developed at Columbia University, where we are very careful in the timing of administration of surfactant, and we give a chance to the babies on bubble CPAP. And of course, bubble CPAP requires a lot of training and nursing training and RT training and physician training in order to make sure that it's a success in these patients. But we will typically administer surfactant based on if the patient requires more than 45-50% oxygen. And these particular patients with RDS. And so we are not currently using lung ultrasound because most studies have been using cutoffs of around 30% to compare lung ultrasound in terms of sensitivity and specificity. And so there's no study yet who have explored it with other criteria or other approaches like the one in Columbia. And the reason we use the Columbia approach of Dr. Wong is that it's been associated with extremely low BPD rates and less mechanical ventilation. And this is the experience that we faced in our own experience as well. So thank you for listening to me. And I hope this little refresher has been useful. And I'm always open for comments and questions. So you can reach out to me at my email, and the contact information is at the end of my website, neocardiolab.com. And so on this note, thank you. And hopefully this was educational and instructive.